So now we are going to shift gears, and we're going to get into the meat of today's presentation, which is comorbidity. And I'm going to walk you through some of the information that we've collected that has gotten us to this point. So first of all, let's just talk about psychiatric comorbidity, which is kind of the thing I'm going to be emphasizing to a great degree today. Now, I've listed here a couple of studies, several studies, just as really placeholders, because there are dozens of studies that have tried over the last couple of decades to estimate the frequency with which individuals who are diagnosed with an ASD also have some type of a psychiatric disorder. And the numbers vary. So I've listed here, 72% of kids had at least one psychiatric diagnosis in addition to autism. 84% of kids in another study met criteria for anxiety disorder. ADHD appears to be have a higher prevalence. When you look at the individual studies, the numbers go all over the place. There's some studies that will report prevalence rates of a psychiatric disorder in autism of 20%, and other ones will report it be 80%. And a lot of that has to do with the clinic you're in, has to do with the population you're serving, it has to do with a whole bunch of other factors that probably don't relate to the core of autism as much as the way in which we see kids and we gather information. So the question has been for some time, is this data reliable, or is this data generalizable? So when you see 70 or 80%, and I would be talking about this, say, 10 years ago, people say, yeah, well, that's probably one study, it's probably not, that's not the kids that we see. And so there was a natural question when we're thinking about here in BC, are these is this information generalizable to here in BC? And so around this time, I was working in the BC Autism Assessment Network, and we're about 3 years into the setup of the program, and we were starting to collect some data on outcomes. And so we decided to take a more close look around our population base and see how much of this reflected what we were hearing about, what we were thinking about, reflected in the kids that we were seeing. So we did this study, and it involved a sequential series of 580 kids who had been referred to the BC Autism Assessment Network. Each of them had our gold standard diagnostic assessment, which included the autism diagnostic interview and the ADOS, Autism Diagnostic Observation Schedule. Of this 580, all of them were also done by a psychiatrist, a child psychiatrist, so each of them also had, in addition to a standard autism assessment, a psychiatric assessment. So there was a psychiatric differential diagnosis that was provided. This is a relatively older sample compared to the overall profile of what we were receiving in referrals at that time. So the mean age here is 8 years of age, and this is very important to keep in mind. We're talking about a school-age population in general. 3/4 of the kids are school age in this population. Only a quarter were under the age of 5. Now, what happens? So these 580 kids go through an assessment, and they have an ADI-ADOS, and they have a psychiatric assessment. At outcome, what we had discovered about this 580 kids around the age of 8 is that only 1/3 of them ended up having autism, and 2/3 of them actually did not have an autism spectrum disorder. Now, this is very interesting for a number of reasons. One from a program planning perspective, it was very interesting because it created difficulties. For us, we were starting to experience extended wait times. Part of the reason we were experiencing extended wait times was because of the 67%. We had designed a program, a model, that was based on about a 50% positive diagnosis rate. Why? That goes into how specialty clinics are always established and kind of reasons for that, and has to do with money and how much funding you had and how much capacity you had. And so when you get up into the 67 and you're seeing very few kids, or relatively few kids, you're ending up seeing a system where you're actually not providing the specialized service that you need. The other thing was 67% don't have autism. They have something. Someone's concerned about them. I mean, it isn't like, we're just going case finding. There's something going on. What is up with these kids, and why does everybody think that they have autism? So we looked a little bit more carefully at the sample, and we looked at various pieces of information that we had. So on this slide, what we've done is I've broken it down into two sides. Let's ignore the colors to start here. And on your left, you have the developmental two developmental bars. And what you see here basically is that individuals who have been referred, these 580 kids, about 2/3 or more, 3/4 of them had some type of developmental diagnosis. Now, this is not a news flash because they're referred to a developmental program. They're likely to have a developmental problem. So this is in addition to autism, or instead of autism, had some type of developmental diagnosis, whether a learning disorder or a developmental coordination disorder or a language disorder or intellectual disability. So 3/4 of them had that. And that stayed fairly stable across the lifespan. Again, intuitive. If you have a developmental disorder, it starts early, it tends to remain chronic. It tends to remain there as part of their profile as they get older. And so you see very little differentiation between the purple bar, which is the under age 5, and the red bar, which is over age 5 in terms of developmental comorbidity. Now let's go to the right there, the psychiatric comorbidity. And this was really fascinating for us. One was that the level of psychiatric comorbidity overall in this sample was extremely high. But what was even more interesting was how it changed over the course of these kids' lives. So you saw that in the kids who were under the age of 5, there was still a fairly hefty number of kids who had some type of a psychiatric comorbid diagnosis. And when I say a psychiatric comorbid diagnosis, I'm including things like ADHD, anxiety disorder, depression, what have you. But when you got into the school-age population, is basically the rule. If you were referred for an autism assessment, you had a psychiatric comorbidity. You would anticipate that was almost predicted, more likely than you had autism for sure. We drilled down a little bit more in terms of the psychiatric comorbidity, and what we discovered was that this particular population of kids, the burden of psychiatric comorbidity looked like this. So it's a little bit different than some people think, because a lot of people, when they think about mental health, they think about depression, they think about psychosis. This is not depression, and this is not psychosis. 2/3 of the kids nearly had ADHD. About 40% of the kids met criteria for an anxiety disorder, 20% of the kids met criteria for a tic disorder, and I put psychotic disorder, schizophrenia up there at 1%, just to give you the reference point that it was exactly the same rate as the general population. So although these ADHD, anxiety disorders, and tics were clearly higher than we would say for the general population. I don't think we have 69% of kids in the world having ADHD. I hope not. But it's the same with psychosis. So there was some separation in terms of the type of psychiatric comorbidity and what was attaching itself, especially in this age group, to autism. And this ADHD, anxiety, tic grouping is what we call the Neuropsychiatric Triad, and you're going to hear a lot more about this today.